way. So we all know that infertility is not a male or female issue. It's a couple problem. So my lecture actually addresses how two classification systems, Aphrodite for male and Poseidon for female, can be used together to provide a more precise fertility care. So they are about 10 years apart. We learned a lot over the last day and so about Poseidon criteria. And perhaps for you, it was the first time you have heard about the Aphrodite classification system that was just published. So, but both are important. So for summarizing the Poseidon classification system, the core concept is that we know that heterogeneity in female patients with poor ovarian response, the introduction of ovarian responsiveness or hyperresponsiveness, and the number of oocytes needed to have at least one euploid blastocyst. For me as a clinician, I see Poseidon like this. There's a system that when I see a patient, I try to understand if my patient will fit in the for Poseidon or non-Poseidon. We use the ART calculator to estimate the number of eggs that could potentially increase my chance of having at least one euploid blastocyst for transfer without doing PGTA. And we use KPI. This is what we do in the clinic. For me, very importantly, Poseidon showed that we have patients with hyper-response, and then I changed my clinical practice accordingly. So what we do at this moment in the clinic is that we try to avoid having this hyper-response before the first trial. So what we do, first of all, we increase the dose of FSH, and we use recombinant LH in all patients, except those patients at high risk of OHSS, hyperresponse. And we have now Delphi consensus that was published recently in JARG, in which shows that we can identify the patients with hyperresponse. So for me, we took a very pragmatic approach in the clinic, giving the combination of recombinant FSH and recombinant LH from the start, all patients. So we can counteract several of the polymorphisms, and we can provide the patient with a more cost-effective way of IVF, we believe, by doing that. So Aphrodite is quite new. So the issue here is that we can, well, improve semen quality and quantity to improve our chances of having not only ART pregnancy, but also natural pregnancy. Just as in the nutshell, it's important also to recognize that these 5 groups, if you think about patients with lowered semen parameters, they can be even azoospermic. So it can be at the low extreme level. So if you go for groups 2, 3, and 4, they differ, but you might find patients with non-obstructive azoospermia inside those groups. And this is very important because this is a concept of the Aphrodite classification that shows that we might be able to improve sperm retrieval rates if we treat the patients with some sort of hormonal modulation before the sperm retrieval. So basically both systems, they have similarities. We have biological markers. They are phenotypic based. We are aiming to personalize counseling and treatment, and they are designed for clinical decision making. Now some more, also similarities or differences. So Poseidon is for women, what Aphrodite is for men. So one used age, ovarian reserve, and response. The other is testicular and sperm parameters. Poseidon identify low prognosis patients, and Aphrodite identify patients potentially eligible for hormonal therapy, and the main outcomes we presented before. And for Poseidon is the endpoint, the main endpoint is cumulative delivery rate, while for Aphrodite is natural pregnancy or ART outcomes. So now, the core part of my presentation, why actually integration matters. Well, we know that infertility is a couple problem. We need to have a synchronized assessment. Both partners, they contribute to the problem, and then we need to make time-sensitive decisions. So what is the case for integration? Well, the systems, they share the same biological, let's say, perspective. And then, especially in our patients undergoing ART, this joint, combination could be useful for estimation, like the chance of pregnancy. This is like for counseling, and also for personalization. We can say, okay, should I change my strategy for ovarian stimulation, accumulation, sperm retrieval, etc., based on the integration? I will try to show you some situations in which, very interestingly, we can do that. And eventually, we can build an algorithm, composite predictive model using that. So this was shown before, but the most important thing about this, paper was that it validates that Poseidon patients, they have low prognosis. And why? Well, because the cumulative delivery rate in Poseidon patients are about 50% lower than normal responders. But even when we kind of go through the different Poseidon groups, we see that they have differences. And these differences are related to, number one, female age, and number two, the number of oocytes retrieved. Well, now let's consider this scenario. So you have a patient, have a look at your left-hand side. So Poseidon group 1, this is the young patient with still adequate ovarian reserve. And now you have from the APHRODITE side, a patient group 2, idiopathic oligoastenoteratosospermia. On the other hand side, you have the same young female patient, and then you have a patient in APHRODITE group 4. This patient need for sperm retrieval. This is one scenario. Now think about the same APHRODITE groups, but now you have older female patient, Poseidon group 2. The markers are still adequate, but she's older than 34 years old. And lastly, just for the purpose of stimulating our thinking, consider now Poseidon group 4, the most severe, phenotype, and now with APHRODITE group 2 versus 4. Well, if I ask you, the prognosis of these patients in terms of cumulative delivery rate is the same, differ? By adding APHRODITE, well, I made this question myself because when Carlo Alvigi invited me to develop this talk, I said, well, this is going to be a difficult exercise. So I went back to the database that we put together a few years ago with Professor Yarali and Dr. Leng Vuong, that was used to substantiate several of the Poseidon papers. And we had in this database over 13,000 patients, in which they used conventional ovarian stimulation. We had the markers, we have cumulative delivery data, and then I made a computation. Here, what I want to show you is very interesting, what I found. So if you consider, for example, here, the young Poseidon patient, and then the cumulative delivery rate when you use ejaculated sperm, and here, Poseidon group 2, older, it goes down with ejaculated sperm, and here it goes down in Poseidon group 4. But look what happens when we combine APHRODITE. Now this is APHRODITE group 2, and this is APHRODITE group 4. The need for sperm retrieval and use of testicular sperm from men, for example, with non-obstructive azoospermia, modulate negatively the cumulative delivery rate. And the other important thing, look what happens in non-Poseidon patients, the good prognosis patients. So here you see APHRODITE group 2 and APHRODITE group 4. So the combination is so important because obviously, if you have these numbers in front of you, the next question is, can integration change the clinical plan? So, well, consider these scenarios. And now we know that with female age, the increase in female age, the aneuploidy rate increases dramatically. This is the paper we published a few years ago, and it was used to kind of validate the 35-year threshold for Poseidon. Here, more than 50% of patients 35 years old and older, they have aneuploidy rates of 50% or higher in the embryos. And not only that, this paper showed that this, decrease in the blastocyst euploidy is not linear with age. With every year, actually, the magnitude of change increases in a non-linear way. So meaning that to counteract the problem of, having this aneuploidy in older patients, we need more embryos and we need more oocytes. So this study shows that the percentage of patients with at least one euploid blastocyst decreases with advanced female age, but we can somehow overcome it by having more embryos, increasing the embryo cohort. Unfortunately, if you go for patients 40 and above, they don't have the high embryo cohort by one stimulation, unless you do the pooling, stimulating using the duet protocol, for example. So, but this information is important because understanding the patient likelihood of having at least one euploid blastocyst can be useful for personalizing the treatment planning for couples undergoing ART. And this was the reason why we developed, a few years ago, a predictive model to estimate the number of metaphase 2 oocytes required for obtaining at least one euploid blastocyst in patients undergoing IVF-ICSI, and we call it ART calculator. So the ART calculator, just for you to have an idea, we used 26 clinical predictors, including patient demographics, semen parameters, presence or not of azoospermia, using of testicular sperm for ICSI in cases of obstructive, non-obstructive azoospermia, gonadotropin dose, treatment protocol, etc. But at the end of the day, we found that in the very elaborated logistic regression models that female age and sperm source were the most important variables in addition to the number of metaphase 2 oocytes impacting the number of euploid blastocysts. So for the first time, we showed a model in which we had something like this. Here you can see the probability, the blastocyst euploid probability per metaphase 2 oocyte. Well, it's expected, and we know that this probability will decrease with increased female age. But what was new is that this is modulated by using testicular sperm from patients with non-obstructive azoospermia. Here you see the line for ejaculated sperm and here you see the line for testicular sperm. So every time you use testicular sperm from patients with non-obstructive azoospermia for ICSI, well, the probability of having a euploid blastocyst per metaphase 2 oocyte decreases. So what does it mean? For these patients, we need more, actually, oocytes. So here is how the calculator works. This is the original, original version of the calculator. But now we have a more, let's say, better interface. So if you want to explore it, it's available for free. You can scan this QR code. I will also present in this QR code in the next 3 slides. So if you don't have time to do it now, don't worry. So basically, we can estimate just by inputting the female age and the type of sperm source, including if it's obstructive or non-obstructive azoospermia in case of testicular sperm. And then after that, you just press calculate, and it will provide an estimate of the minimum number of metaphase 2 oocytes needed to achieve at least one euploid blastocyst for transfer in patient with the 95% confidence interval. So just to give you an example here, and so the QR code will be there again. So in the scenarios I presented before, you see that Poseidon group 1 when it's ejaculated sperm, the calculator said, okay, we need 5 metaphase 2 oocytes with the confidence interval between 3 and 6. When you go for testicular sperm, you need to adjust your estimation because it's now 8, and the interval is between 5 and 10. So the second scenario, now older Poseidon patient, group 2, you see now it's 10 for ejaculated sperm and it's 13 for testicular sperm. In the worst case scenario now is 17 for Poseidon group 4 and Aphrodite group 2, I mean ejaculated sperm, and then you go for the worst combination, it's now 20. Well, now I ask you, would you perform the same strategy having these numbers in front of you? I believe most of us will agree that we need to change the clinical plan. So I'm not saying that now, presenting just a few slides in terms of how I do. I'm not telling you that you need to do that. But the message here is that we need to think on strategies from the beginning, classifying the patient if it's a potential Poseidon plus Aphrodite. What's the treatment protocol would you consider in the patient like Poseidon group 1 and a patient that use ejaculated sperm? You can estimate the number of oocytes, and in those patients, we know that we can optimize the results by doing pharmacological interventions. We know now by the lecture of Lin that we can improve the sperm parameters as well, and could be useful for actually make the treatment more effective. And then you can also consider what is the trigger oocyte pickup strategy, the embryo transfer, the luteal phase support. And then, for instance, if you move to now Poseidon group 2, the older patients, and then you need to understand if the patient has this hyporesponsiveness that you provide the pharmacological interventions, or if this patient is actually, you have explored the number of oocytes she had, and then you need to do, the dual stim protocol, things like that. So this is important because it's the way I'm thinking now. Well, let me see if my treatment can be more precise by integration. And the integration can mean, thinking about the number of oocytes I would need for specific treatment combination, and then what I can do actually to make my treatment more precise. Now, consider the other Aphrodite patients. Now, we are using the same, Poseidon groups 1, 2, and 4, but now I'm talking about Aphrodite group 4. These patients, usually they have non-obstructive azoospermia. They have usually low testosterone levels, FSH levels are in the upper normal limits or above the normal limits. They are azoospermic, and usually the treatment that we have been using historically is what? Sperm retrieval. However, there's a possibility that this patient can also benefit from hormonal stimulation before sperm retrieval. And this has been shown by some authors. We recently published, also in Fertility Sterility, our series of more than 600 patients in which, by using hormonal modulation before the sperm retrieval, to boost intratesticular testosterone production and help actually to these patients with still germ cells and some sperm in the testicle, we could actually improve the sperm retrieval rates. So for me, when I see this combination now, I think, well, I know that in this patient category, because I want to increase the chances of having sperm in the sperm retrieval, I do pre-sperm retrieval hormonal modulation, number one. Second, I need to understand how many eggs I need in these patients, because as I showed you before, I need to adjust my estimation. I need more eggs. Then I need to understand what's the best possible treatment protocol for that particular couple. Is it, I need to vitrify oocytes and then do a second stimulation. Consider the case, as we do, I did my pre-sperm retrieval hormonal stimulation for 5 months sometimes. And I take sperm by microtessy, which is the approach we use, and we freeze sperm. So now we know that the patient has own sperm frozen. And then I go for the art calculator and say, okay, now I need maybe 15 eggs. And then I need to achieve this 15 metaphase 2 oocytes. How? We start doing oocyte vitrification. When I achieve a certain number of oocytes, we do another stimulation, and then we have fresh and frozen oocytes, and we go for ICSI with, testicular sperm. So this is just, a way of thinking about how we could potentially optimize the treatment outcome by doing the combination. Obviously, the APHRODITE is still in early days. We need more studies in terms of the validation. POSEIDON is also evolving. We are thinking about now the need to include the KPIs. And we need, of course, studies coming from your centers as well, your groups, that could integrate these metrics. And then by sharing, the data with us in future publications, we can actually go ahead with more information. So what's the research outlook looks like? We need studies for this combined classification in patients undergoing ART. Specifically, we need to validate the integrated classifications. The endpoints could be time to pregnancy, could be cumulative delivery rate, could be cost effectiveness analysis. And we come to the conclusion that the APHRODITE and POSEIDON offer actually complementary views. We can use this unified approach to improve the fertility care we offer our patients and making it more harmonized for especially the low prognosis patients. For me, then, it's like these two patient systems, they reflect, like the two halves of the same coin. And I think by using them, we can actually provide more precise fertility care for the couples we treat. So I'd like to conclude just by acknowledging my dedicated team at Androfertility Clinic in Brazil, also my academic institutions and the collaborators that I made along this journey, many from Italy, Germany, Turkey, and other countries, and Denmark with Professor Humaydan as well, Professor Simoni. So this collaboration is actually very important for us to advance our field, bringing male infertility also to the central stage. Thank you very much.